If you ask, um, like the average person on the street to picture someone with PTSD, 9 times out of 10, they're going to picture a calm veteran.
Yeah.
But statistically, the person most likely to be walking around with this diagnosis isn't a soldier.
Mm-hmm.
It's actually a woman who survived a sexual assault. Like, according to the clinical data we're looking at today, half of all sexual assault survivors develop PTSD.
Yeah, it's staggering.
Half. So today, we're basically tearing down almost everything pop culture has taught you about psychological trauma.
And it's so desperately needed, honestly, because the mainstream narrative around trauma creates just a tremendous amount of isolation for people.
Oh, totally.
Like, people look at their own suffering, they look at their own nervous system just, spinning out of control, and they think, well, I don't look like that character in the war movie, so what's wrong with me?
Right. Like, why can't I just get over this?
Exactly.
And that is exactly why you're here with us for this deep dive. Our mission today is to cut through those really narrow, highly dramatized Hollywood stereotypes and look at the actual clinical reality.
Yeah, the real data.
Right. So we're pulling from this incredibly comprehensive clinical overview provided by Coping and Healing Counseling, or CHC, to look at post-traumatic stress disorder.
Mm-hmm.
We're going to explore what it actually is, how it systematically hijacks the brain, and most importantly, the evidence-based treatments that actually rewire those neural pathways.
Because it's not just about, feeling sad or stressed.
No, not at all. It's about physical biology. So, okay, let's unpack this.
Yeah, to lay the absolute foundation here, it is crucial to understand how the DSM-5, which is, the standard classification manual for mental health professionals, how it views this.
Right.
PTSD is categorized specifically as a trauma and stressor-related disorder.
So it's not an anxiety disorder.
No, it's not. And it's certainly not a character flaw, and it's definitely not a sign of mental weakness.
Which is such a huge misconception.
It's huge. It's a highly specific physiological and psychological response to a traumatic event. Basically, your brain is doing exactly what it was designed to do, which is keeping you alive in a dangerous situation.
Okay.
The disorder happens when the brain fails to turn that survival mechanism off once the danger has actually passed.
Which perfectly brings us to the numbers, because the sheer scale of who this affects is just staggering.
Yeah, it really is.
The lifetime prevalence of PTSD in the U.S. is near 6.8%. And the 12-month prevalence, meaning people who've met the criteria within the last year alone, is near 3.5%.
Which is millions of people.
Millions.
And as you mentioned at the top of the show, the demographic breakdown is incredibly revealing. Women are diagnosed at roughly twice the rate of men.
Wow. 2 to 1.
Yeah. And combat veterans absolutely have elevated rates. It's around 10 to 20% depending on the conflict era. But that 50% rate for sexual assault survivors completely upends the public narrative of who, owns this diagnosis.
It really does.
Yeah.
But, going through the source material, what really shocked me was what actually qualifies as a trigger.
Mm-hmm.
The DSM-5 defines a trauma trigger as exposure to actual or threatened death, serious injury, or sexual violence, which, makes sense. But it says the exposure can be direct or it can be indirect.
Right.
Wait, how can you be deeply traumatized by something that didn't physically happen to your own body?
Well, what's fascinating here is how the human nervous system interprets an existential threat.
Okay.
It's not strictly confined to a physical assault on your own person. The criteria specifically include learning of violent harm to a close family member.
Oh, wow. So just hearing about it.
Exactly. Or, and this is a massive one, repeated occupational exposure to traumatic events.
Like first responders or emergency room doctors.
Precisely. Think about paramedics, healthcare workers, police officers. They're constantly exposed to the gruesome aftermath of trauma.
Right. Day in and day out.
Yeah. And neurologically, your brain is processing that repeated, indirect exposure as a profound threat to safety. The brain's threat detection center doesn't always differentiate between this is happening to me and this is happening right in front of me over and over.
That is wild.
It just proves that trauma triggers are vastly broader than we think. I mean, it includes serious accidents, sudden or violent loss, medical trauma, childhood abuse or neglect, witnessing violence, and, the experiences of refugees fleeing conflict.
Okay, so if someone has this exposure, whether direct or indirect, how do we actually separate normal human grief or shock from a clinical psychiatric disorder?
That's the big question.
Right, because you can't just take a blood test for this. So how does a clinician actually diagnose it?
You're right, there's no blood test, but the diagnostic process is highly structured. First, as a critical gatekeeper, the symptoms must last for more than 1 month.
Okay, more than a month.
Yes, and they must cause significant distress or impairment in the person's social, occupational, or other important areas of functioning.
So it has to really disrupt your life.
Exactly. And importantly, this diagnosis has to be made by a licensed clinician. That means a psychologist, a licensed clinical social worker, a licensed professional counselor, a licensed marriage and family therapist, or a psychiatrist.
So absolutely no self-diagnosing via social media.
Absolutely not. Please don't do that. Clinicians use highly structured interviews and validated measures for this. The source highlights tools like the PCL5 and the CAPS5 to assess these symptoms.
Hold on. For those of us not sitting in a clinician's office, what do those acronyms actually mean? Are those like brain scans?
No, they aren't imaging tools. The PCL5 is a standardized 20-item self-report questionnaire. It basically tracks the severity of symptoms over time.
Okay, got it.
And the CIPS-5 is considered the gold standard clinical interview. It's a very specific, guided conversation where the clinician asks targeted questions to evaluate the frequency and intensity of the symptoms.
And what are they looking for in that interview?
They're looking to see if those symptoms fall into 4 very specific, distinct clusters.
Okay, let's get into those 4 pillars, because I feel like this is where the daily reality of the disorder really takes shape for people.
Definitely.
The clinical data calls Cluster 1 intrusion symptoms. And this includes recurrent intrusive memories, distressing dreams, dissociative reactions or flashbacks, and intense psychological or physiological reactions to trauma cues.
It is essentially the past relentlessly, violently invading the present.
Yeah, and reading about this, it made me think of how memory is supposed to work versus how trauma breaks it.
I like this. Go on.
So imagine your brain's memory processing center, the hippocampus, is a really meticulous librarian.
Okay.
Normally, when an event happens, the librarian stamps the book, categorizes it, and files it away neatly in the past section.
Right, where it belongs.
But trauma is like a massive earthquake hitting the library. The librarian drops the books in a panic,
Yeah.
and they just scatter all over the floor of the amygdala, which is, your brain's primal fear center.
Yes, the alarm system.
Right. So instead of being neatly filed in the past, these terrifying memories are just lying out in the open. And you keep tripping over them in the present.
That is a phenomenal metaphor. Because the memory hasn't been properly filed with a time and date stamp, the brain reacts as if the event is happening right now.
The threat feels completely current,
Exactly.
which logically leads to Cluster 2, which is avoidance. Like, if your brain keeps tripping over these terrifying memories, the natural human response is to run away from them.
Of course it is.
And the source defines this as the persistent avoidance of trauma-related thoughts or feelings, but also avoiding external reminders, people, places, conversations, or activities. But I have to push back here a little bit. Isn't it just normal human nature to avoid things that scare you?
Well, yes.
I mean, if I get into a horrible car crash at a specific intersection, avoiding that intersection seems like common sense, not a clinical disorder. When exactly does a preference become a pathology?
That is the exact question a clinician has to evaluate. It crosses the line into a disorder when it hits that threshold we mentioned earlier, significant distress or impairment.
Okay.
If you take a different route to work to avoid that intersection, that's a coping mechanism. But if you stop driving entirely, if you quit your job because you can't handle the commute, if you refuse to get into a vehicle, even if someone needs to go to the hospital, your avoidance is now severely impairing your life.
Right.
The disorder is basically shrinking your world down to an unlivable size.
Okay. The impairment is the key. It's when your world becomes a prison of avoidance. So if you're constantly dodging triggers and isolating yourself, how does that chronic avoidance actually change a person's personality or worldview over time?
Well, that brings us exactly to Cluster 3, negative alterations in cognition and mood.
Okay.
When your world shrinks, your perspective warps. This can include an inability to remember key features of the trauma, but it also involves persistent and exaggerated negative beliefs.
Like what?
Thoughts like, I am permanently broken, or the entire world is completely dangerous. You often see distorted blame where the survivor blames themselves entirely for what happened.
Oh, that's heavy.
It is. And there's this persistent negative emotional state living in constant fear, anger, guilt, or deep shame.
The overview also mentions an inability to experience positive emotions, anhedonia, just a total inability to feel joy or happiness or connection to others.
It's a profound numbness. The brain is spending so much metabolic energy trying to manage the terror that it simply shuts down the capacity for joy.
Wow. And if you genuinely believe the world is entirely dangerous and you feel entirely detached from other people, your physical body must constantly be braced for impact.
Yes, absolutely. And that is cluster 4, marked alterations in arousal and reactivity.
Okay.
The body is locked in a state of high alert. This looks like irritable behavior, angry outbursts out of nowhere, reckless or self-destructive behavior, extreme hypervigilance, an exaggerated startle response, and severe problems with concentration and sleep.
So your nervous system is basically redlining all the time,
Yeah.
like a faulty car alarm that blares just because the wind blew.
Precisely. And living with that constant internal alarm takes a massive, measurable toll.
I can imagine.
The source data notes that PTSD frequently co-occurs with depression, substance use disorders, anxiety, and crucial physical health conditions like chronic pain and cardiovascular disease.
Wait, cardiovascular disease?
Yes, the constant, unending flood of cortisol and adrenaline damages the physical heart, not just the mind.
So what does this all mean for the timeline of trauma? We established that the DSM requires these symptoms to last for a minimum of 1 month.
Right.
But obviously the car crash or the assault happens on day one. What exactly is happening in a person's brain during those first 29 days? Are they just in diagnostic limbo?
Well, the clinical framework actually accounts for that window. For the initial period after a trauma, the diagnosis is acute stress disorder.
Okay.
It has very similar criteria to PTSD, but it applies specifically to symptoms lasting from 3 days up to 1 month after the event.
So the initial shock, the brain reeling from the event, is recognized clinically, but it isn't automatically PTSD.
Exactly. The brain needs time to process. And the source explicitly notes that many cases of acute stress disorder naturally resolve on their own before the criteria for full PTSD are met.
Oh, that's interesting.
Yeah, going back to your metaphor, the librarian eventually manages to pick up the books and file them away. It's a normal acute reaction to an abnormal situation.
Right.
But then you have the complete opposite end of the spectrum, which is complex PTSD.
Oh, yeah. The clinical brief notes complex PTSD is a proposed diagnosis in the ICD-11, which is the International Classification Manual. And it specifically deals with chronic exposure to interpersonal trauma.
Right. Think about situations where the trauma isn't just one bad day, it's prolonged, and escape is difficult or impossible.
Like what kind of situations?
Severe, repeated childhood abuse, long-term domestic violence, human trafficking. This prolonged exposure creates disturbances that go beyond those 4 standard clusters we just discussed. It fundamentally disrupts self-organization. You see profound negative self-concept, severe emotional dysregulation, and deep, lasting relationship difficulties.
It's a difference between surviving a terrible earthquake and surviving years of someone systematically telling you that you're worthless.
Exactly.
The chronic, inescapable interpersonal trauma basically alters your baseline concept of who you even are as a human being.
Which is exactly why treatment approaches have to be carefully tailored. You aren't just processing a single horrific memory, you're rebuilding a person's entire framework for trusting themselves and trusting the world.
Okay, we've covered a lot of heavy, difficult reality here. The symptoms, the biology, the physical toll. But here's where it gets really interesting.
Yeah.
Because PTSD is not a life sentence.
No, it's not.
The source data provides an incredibly robust look at the evidence-based treatments that actually work. We're talking about actively rewiring the brain.
Yeah.
Let's look at the therapies first.
Sure. The clinical consensus points to several highly effective structured psychotherapies. First is trauma-focused cognitive behavioral therapy, or TFCBT, which has very strong RCT evidence.
And just to clarify for the listener, RCT stands for randomized controlled trials, right?
Correct.
The absolute gold standard of scientific proof, meaning we know for a fact this works better than just a placebo or standard talk therapy.
Exactly. We also have cognitive processing therapy, or CPT.
The brief says CPT is recommended by the VA, takes about 12 sessions, and specifically targets stuck points and trauma-related beliefs. So it's attacking those negative cognitions from cluster 3, but how does it actually do that?
Well, a stuck point is a core belief that got frozen at the moment of trauma. For example, if someone survives a horrible accident where others didn't, a stuck point might be, it is entirely my fault because I survived.
Oh, survivor's guilt?
Exactly. CPT actively interrogates that belief. It puts that specific thought on trial, challenging the distorted blame until the brain learns a more balanced narrative.
That's incredible.
Another VA-recommended option is prolonged exposure, or PE. This directly tackles the avoidance in cluster 2 by safely exposing the patient to the memories or situations they've been fleeing from.
Wait, exposing them to the memory. How does making someone relive the worst day of their life actually heal them? Doesn't that just re-traumatize them?
I know it sounds counterintuitive, but it relies on a mechanism called habituation. Habituation is basically neurological boredom.
Neurological boredom.
Yeah, if you expose the brain to a safe, controlled version of the memory over and over again in a therapist's office, the amygdala eventually stops sounding the alarm.
Oh, I see.
It realizes, oh, I'm sitting in a safe room, I'm not actually back in the war zone or the car crash. It rewires the brain's association from a current active threat to a historical fact.
That makes total sense. You're teaching the brain that the memory itself cannot physically hurt you.
Right.
And then there's EMDR, eye movement desensitization and reprocessing. The source notes it's widely used with strong evidence. But, this one always sounds a bit like sci-fi to people. How does moving your eyes back and forth fix a trauma?
It utilizes bilateral stimulation like guided eye movements or alternating tapping on your hands. The theory is that this mimics the biological mechanisms of REM sleep.
Oh, the sleep phase where we dream.
Right. REM sleep is when our brain naturally processes daily events and consolidates memories. By inducing that bilateral brain activity while the patient briefly focuses on the trauma, it jumpstarts the brain's natural healing process. The emotional charge is drained from the memory.
Wow, taking that scattered book off the floor and finally putting it on the shelf in the past section.
Exactly. Now, alongside therapy, there's pharmacotherapy medications. The sourceless SSRIs, specifically sertraline and paroxetine, which are FDA approved for PTSD.
SSRIs being selective serotonin reuptake inhibitors, which help regulate the mood and neurotransmitters in the brain.
Right. And SNRIs like venlafaxine have moderate efficacy. There's also a medication called prazosin, which is fascinating. It's actually a blood pressure medication, but it's been found to specifically help reduce PTSD-related nightmares by blocking adrenaline receptors in the brain.
Okay, but looking at the medication list, I have to stop and ask about the what to avoid section.
Oh, yeah. This is crucial.
It says benzodiazepines should generally be avoided in PTSD because they can actually worsen outcomes. If you're listening to this and your nervous system is constantly braced for impact, shouldn't a central nervous system depressant like Xanax or Valium be exactly what you need to calm down? Why would they make trauma worse?
If we connect this to the bigger picture, it makes perfect neurological sense. Benzodiazepines essentially numb the brain to provide immediate short-term relief from panic.
Right.
But remember what we just said about the mechanisms behind CPT, prolonged exposure, and EMDR?
They require the patient to actively engage with the memory. Habituation. Processing.
Exactly. You cannot process a trauma if your brain is chemically numbed. Benzodiazepines prevent the neurological rewiring that those evidence-based therapies are trying to achieve.
Oh, wow.
Furthermore, they reinforce the avoidance cluster. You're running away from the feeling via a chemical rather than moving through the feeling to heal it. Relying on them can actually cement the trauma in place, worsening the long-term prognosis.
Wow. That is an incredible insight. It highlights exactly why generalized anxiety treatment is not the same as specialized trauma care.
No, it's very different.
The source also mentions some emerging options like MDMA-assisted therapy, which is currently under FDA review, and ketamine, though it notes there's limited clinical evidence for ketamine right now. The core really remains those established psychotherapies.
Yes, the landscape is evolving, but the foundation is active therapeutic processing.
Which leads us to a massive practical problem.
The bottleneck.
Yeah. We have these incredibly specific, evidence-based tools that require specialized training. But traditionally, finding a therapist who is actually trained in EMDR or CPT and who also takes your health insurance and who lives within driving distance of your house is like trying to find a needle in a haystack. It's a massive systemic bottleneck.
It is one of the biggest barriers to mental health care globally. But looking at the clinical overview from CHC Coping and Healing Counseling, it's interesting how they're attempting to solve this exact bottleneck. They operate as a 100% telehealth IPA-compliant practice serving all 159 counties in Georgia.
Which means if you live in a rural area, you don't have to drive 3 hours to a major city just to find a trauma specialist.
Exactly. The geographic wall is gone. They have a diverse, culturally competent team of over 15 licensed therapists, LCSWs, LPCs, LMFTs, and critically, their clinicians include therapists specifically trained in EMDR and CPT.
So you're getting direct access to the exact neural rewiring mechanisms we just discussed.
Yes. They also track patient symptoms using the PCL5, ensuring the treatment is actually working and data-driven.
And they tackle the financial wall, too. Often people don't get help simply because they can't afford out-of-pocket specialists. According to the brief, CHC accepts Medicaid, which is a $0 copay for the patient.
That's huge.
They also accept major commercial plans like Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana. Sessions with those insurances typically run between just $10 and $40.
That level of financial accessibility for highly specialized trauma care is a game changer. I also want to highlight a crucial structural detail: they actively coordinate with the patient's primary care physician.
Right.
We discussed earlier how PTSD damages the cardiovascular system with chronic stress hormones. Coordinating care ensures they're treating the whole person, the physical heart, alongside the mind.
That is so important. If you're listening to this and you recognize these patterns, if your world has shrunk from avoidance, if you're constantly tripping over intrusive memories, or if you feel permanently braced for impact, please do not try to tough it out.
Absolutely.
You can connect with CHC by visiting their website at cinetherapy.com, emailing them at support@cgtherapy.com, or calling directly at 408-320-002. And if you or someone you love is in immediate crisis, please call or text 988 to reach the Suicide and Crisis Lifeline.
Healing requires reaching out. The structural barriers are falling, and the evidence shows that recovery is absolutely possible.
To wrap up our deep dive today, the most important takeaway from all of this clinical data is a message of profound hope. PTSD is incredibly complex, yes. It's biologically disruptive, yes. But it is highly treatable. You are not broken, you are injured. And the brain's neuroplasticity means those neural pathways can be rewired with the right tools. You can teach the amygdala that the threat is gone. You can pick those scattered books up off the floor.
The human capacity for resilience is staggering. But this raises an important question. If, as the clinical data shows, many cases of acute stress disorder naturally resolve on their own before turning into PTSD, what exactly is the mechanism?
Oh, that's a great point.
Yeah, what is the specific environmental or biological factor that allows one person's brain to successfully process and file away a severe trauma within those first 30 days, while another person's brain gets structurally stuck in a loop for years?
That is a fascinating thought to hold on to as we sign off. What makes the difference in those first 30 days? We went from thinking of trauma as an invisible, untreatable weight to understanding the very real, very mechanical ways the brain can heal itself. Thank you for joining us on this deep dive.